Today we are going to delve into the world of gastroenterology in internal medicine with a fairly common clinical complaint called dysphagia. So let's get into it. All right. To start off, let's look at the meaning of this word dysphagia. It is a combination of two words. Dys, as you means, is derived from disturbance. So any problem, dys means generally in medicine, a difficulty or any pathology. And phagia means to eat. So in this context, we are going to refer to the word phagia as swallowing, as the swallowing mechanism. So difficulty in swallowing. This is the literal meaning of this term dysphagia. And this is how we define dysphagia. Anything which leads to the difficulty in the swallowing process, a normal physiological swallowing process, is termed dysphagia. Now, dysphagia itself is not a clinical disorder. It is a presenting complaint or a symptom of any underlying pathology. So whenever we have any patient presenting to us with this symptom of dysphagia, we do a proper and thorough workup to look at the what can be the underlying pathology that can cause it, or it can be a manifestation of any normal process going on, which is a fairly benign condition. So a wide variety of diseases can present as dysphagia. So it is important because most of the time the underlying pathology is very easily fixable or very easily treatable. So it is important to rule out various diseases and to do a thorough and proper workup. And it can also be a manifestation of something very serious like a neoplasm, which is presenting at dysphagia. So whenever there is some long-standing dysphagia, it is important to do a proper thorough workup via proper history and examination to look at the various pathologies that can present with this condition. Now, in this lecture, we are going to go through the normal physiology and the normal pathophysiology initially, and then going to classify the disease, this dysphagia, according to the etiology or according to the location where it presents. So to define dysphagia, it is any process which leads to the difficulty in the swallowing process, beginning right in the mouth, all the way up to the lower esophageal sphincter, to which the swallowing process is generally confined to. Your mouth, your oropharynx, your pharynx, hypopharynx, then the esophageal part of the dysphagia. These are the various parts which are involved in the swallowing process. All right. To elaborate further, let's look at the normal. To know the abnormal, you have to know the normal first. So let's look at the physiology of swallowing. Okay. So before going into the detail of this diagram, I just want to go through the anatomy a bit. Just as I told you, the whole process of swallowing starts right from the mouth. When you take the food in your mouth, you start mastication, and the process of the swallowing begins here. So after the food is ingested and broken down or masticated in the mouth, it goes through this oropharynx, and then oropharynx, it goes right below. This part is called the pharynx, and the part below the pharynx is called hypopharynx. And afterwards, this is the upper esophageal sphincter, which is formed of various musculature involved in the pharynx and the hypopharynx, and downwards there is the esophagus. This is the larynx, and this is the cricoid cartilage, which normally closes during the swallowing. So if we start and look at the anatomy, the upper part of the esophagus, including the upper esophageal sphincter, is generally composed of the striated muscles. Along with the pharynx and the oral cavity and the muscles of the mouth, they form a striated muscle complex which are innervated by the various cranial nerves. For example, the muscles of your face are generally innervated by the 7th cranial nerve, facial nerve, or the 5th nerve, trigeminal nerve. The muscles of the pharynx are generally innervated by the 9th and the 10th cranial nerves. Similarly, the upper esophageal sphincter, which is generally made by the cricopharyngeus muscle and the lower pharyngeal constrictors, it is generally innervated by the 10th cranial nerve, the vagus nerve. So there is a lot of voluntary control involved here. But the lower part of the esophagus is generally, the lower third and the lower esophageal sphincter is generally composed of the smooth muscle cells. So the dorsal motor nuclei of the vagus nerve in the medulla, they go and form the innervation there via sympathetic and the presympathetic nerve. So it is an involuntary control. So this is important to remember in the context of the physiology of swallowing, to understand this process, that the upper and up to the middle thirds of the esophagus is generally composed of the striated muscles, and the lower third and the lower esophagus sphincter is generally there is generally smooth muscle innervation. And in the lower esophageal sphincter, there are excitatory and the inhibitory neurotransmitters. The excitatory neurotransmitters, which basically vagus nerve, the predominance is of the parasympathetic nervous system in the lower esophageal sphincter. So the excitatory neurotransmitters, which are basically acetylcholine and substance P, they generally keep the lower esophageal sphincter tonically constricted in the normal person to prevent the reflux of the acid from the stomach into the esophagus. When there is a swallowing process, the lower esophagus sphincter is dilated because of the release of certain neurotransmitters, the inhibitory neurotransmitters like the vasoactive intestinal peptide, or the VIP, or nitric oxide. These are the vasodilatory neurotransmitters which keep the lower esophagus sphincter open during the swallowing process, or the peristaltic waves, to allow the food to pass from the esophagus to the stomach. All right. This is the basic anatomical consideration. Let's look at the various parts involved, and then we are going to go stepwise in how the physiology process takes place. As you can see, if we label the diagram, this is the hard palate, the underneath is the soft palate. If you go further, this is the food bolus shown here. Now the tongue, epiglottis, glottis, and this is the upper esophageal sphincter, which is basically made of cricopharyngeus muscle. So there are two phases of the swallowing process in the initiation process. The first is the voluntary phase. When we take the food in the mouth and we start mastication, this is the voluntary process. And then when the food is masticated or broken down into small pieces, we transfer the food to the back of the throat or the oropharynx. And this is called the transfer phase. The food is transferred into the pharynx. And here the process of swallowing, or the swallowing reflex, starts. It is basically a reflex mediated by the brainstem, controlled by the various factors, and there are peristaltic waves which begin as the food is passing from the pharynx to the esophagus. As you can see, this is the oral phase, or the voluntary phase, in which you masticated the food. Afterwards, when the food passes to the pharynx and moves down into the hypopharynx, it initiates a peristaltic reflex, peristaltic wave of swallowing. This is called a primary peristaltic wave of swallowing. What happens in this is, look, the tongue is raised and it obliterates the oropharynx to avoid the reflux of the food backwards into the nasal cavity or out of the mouth. Similarly, at the same time, the epiglottis is moved backwards and downwards, and the larynx is raised upwards to close this glottis, this opening. This is very important to avoid the food going into the trachea. Otherwise, we'll aspirate our food and there will be problems. So this natural process of the movement of the larynx upwards and the movement of the tongue backwards to close the glottis and the nasal cavity, or the nasopharynx, this is what generally protects our airways and avoids any problems of breathing during the swallowing process. This is a very quick process. This transfer phase, it lasts for a second, the pharyngeal part of the swallowing. Afterwards, at the similar time, the upper esophageal sphincter, as you can see, it is opening and it starts accommodating the food. Afterwards, when the food passes through the upper esophageal sphincter into the esophagus, it generates a peristaltic wave, which starts with an inhibitory process. Inhibition means there is distal relaxation. Whenever the food passes through the pharynx, the esophagus down underneath is relaxed to accommodate the food. This is generally termed as deglutitive inhibition. This term is used in the context of swallowing, and there are three components of this peristaltic wave. It starts with the deglutitive inhibition or relaxation of the esophagus underneath, and afterwards, when the food passes, there is a contraction wave from the backside of the food to allow the food to propel downwards and avoid its reflux or upward. So the first part is deglutitive inhibition or relaxation, you can say. Then there is a peristaltic contraction leading to the distal movement of the food. And just as the food enters the esophagus from the upper esophageal sphincter, the upper esophageal sphincter closes and the lower esophageal sphincter opens. This is because to allow the complete passage of food from the esophagus to the stomach. So this is the naturally reflex mechanism which is involved in the physiology, and it is very important to understand because there are various components and the various nerves involved. And when you understand the normal, it becomes fairly easy to understand the pathology or the abnormal. So just remember that there are two parts. Initially, there is the oropharyngeal part of the swallowing, and then there is the esophageal part. The oropharyngeal part is divided into the two parts. First, when we take the food, this is the oral part or the voluntary phase in which we masticate the food. Afterwards, when the food passes through the pharynx, there is a transfer phase in which through the hypopharynx, the glottis, the opening of the glottis is closed by the epiglottis in the larynx, and the upper nasopharynx is closed by the movement of the tongue backwards. This allows the food to propel through the esophagus, leading to the generation of a primary peristaltic wave, which includes the deglutitive inhibition, and then afterwards it is preceded by the contractile phase of the primary peristaltic movement. Here you can see after the food has passed through the pharynx into the esophagus, the upper esophageal sphincter, this will soon close, but the glottis has opened now because this food has passed through the pharynx, and the upper part of the whole the swallowing process gets into its normal physiology. All right. After understanding the physiology, let's look at a few related terms to dysphagia. We'll start off with the term aphagia. A, as you know in medicine, means absence. So aphagia means absence of swallowing or generalized inability to swallow. This is generally an acute process occurring, for example, if there is some foreign body impaction in the esophagus, or there is some food bolus obstructing the pharynx or the esophagus. This leads to a complete inability to swallow, and this is termed as aphagia. This is generally an emergency process in which we have to remove the foreign body or the any food impacting here. Afterwards, there is a term called odynophagia. Odynophagia means painful swallowing. So whenever there is pain with swallowing, you have to think of some infectious or inflammatory pathology. There can be an inflammatory process going on, especially, and we have to look at in the bigger picture in the context of the patient's general health. If the patient is generally in good health, then this can be a fairly benign process. But if the patient is immunocompromised, for example, someone who has neoplasia, or someone who is malnourished, like a diabetic person or someone with HIV, then this can be a fairly devastating process. For example, in patients with HIV, if we have odynophagia, our mind should go to it can be an underlying neoplasm like a Kaposi sarcoma, or it can be a herpes simplex esophagitis, or a CMV esophagitis, or for example, a Candida esophagitis. So generally, whenever there is odynophagia or pain during the swallowing process, it generally denotes an inflammatory or an infectious process. Globus pharyngeus is generally a sensation of something sticking in the in the pharynx. For example, a sensation of some swallowing in the pharyngeal region, which is generally not causing dysphagia, and it generally goes on with the swallowing process. So this is just a term to remember. It is not related to the dysphagia going on. Transverse dysphagia is as the name signifies, any pathology that interferes with the transfer process. For example, any structural abnormality in the pharynx which leads to the difficulty in transferring the food from the mouth or the oral cavity into the esophagus, that can lead to the transfer dysphagia. Or there can be a motor pathology, any motor neuron disease or some neurological process which can lead to transfer dysphagia. We are going to go into the details of certain motor disorders that can cause dysphagia in the coming slides. Now, phagophobia is generally a term which is, you can say, can be a psychiatric issue. There is generalized discomfort during swallowing, or the patient is fearful of the swallowing process. This can be a psychological disorder, or it can be related to the previous bad experiences of having odynophagia or difficulty or pain during the swallowing process. So these are a few related terminologies which you should be aware of in the context of dysphagia. All right. Now let's get into the pathophysiology. After understanding the physiology, let's look into what can go wrong during this normal physiological process. Dysphagia can be classified either by the location or by the disease process which is causing the disease. If we go by the location, we can, as you know, there are three parts generally involved in the swallowing process. To start off, we have the oropharynx or the oral part. Then it is the pharyngeal part or the hypopharynx involved. We generally use the term oropharyngeal dysphagia for any pathology involved, right, starting from the oral cavity up to the pharynx, up to the upper esophageal sphincter. We classify them as whole as the oropharyngeal dysphagia because there is generally a similar process going on in the both parts of the oral cavity and the pharynx, which is causing this dysphagia. And the signs and symptoms are generally the same. And the other classification is the esophageal dysphagia. This is anything starting from the upper esophageal sphincter up to the lower esophageal sphincter. There are two parts of the esophagus, as we know, starting from the upper esophageal sphincter up to the sternal angle of Lewis. We classify that as cervical esophagus, and underneath we classify from that sternal point of Lewis to downwards up to the lower esophageal sphincter, or the where the esophagus penetrates the diaphragm. We classify it as thoracic esophagus. So esophageal dysphagia can be further classified into cervical esophageal or thoracic problem, because but generally both of them present with the same signs and symptoms. So we avoid this complexity and classify them as esophageal dysphagia. So the two to remember generally are oropharyngeal and esophageal dysphagia by the location. Now, if we go by the pathology causing the dysphagia, we can classify it as either any structural disorder. For example, either the bolus of food is too big to pass through the cavity, or the cavity or the lumen of the cavity is too narrow to accommodate the normal bolus of food. So any structural problem which leads to the inability of the food to pass all the way through the stomach can be classified as a structural dysphagia. The other part is the propulsive or the motor dysphagia. The motor dysphagia is any problem in the generalized tone of the esophagus, or any neural pathology going on which leads to the inhibition of either the generation of the peristaltic wave, any problem in the generation or the sustenance of the peristaltic wave, or any problem in the lower esophageal sphincter, for example, the lower inability of the lower esophageal sphincter to relax in certain conditions. Those we term as motor or the propulsive dysphasias, where there is no structural pathology, but there is generalized problem with the peristalsis or the tone of the sphincter or the tone of the gut, tone of the esophagus. All right. Now let's look at the few etiologies in the context of this discussion. To start off, if we have a patient presenting with dysphagia, the patient comes to us in your clinic and he says that, doctor, I have a difficulty in passing food down my throat, or I have inability to swallow. The first thing from the history we have to look into is either the problem is in the oropharynx or whether the problem is in the esophagia. If the patient comes to us and says that there is drooling of the food or the saliva from his mouth when he's swallowing the process, or there is a generalized sensation of getting the food stuck in the back of the throat, or whether there are certain associated symptoms like the aspiration of the food or the nasopharyngeal regurgitation of the food through the nose, then you can say fairly confidently that this is a problem with the oropharynx and the oropharyngeal part of the swallowing process. If, on the other hand, the patient presents to us and he says that, pointing with his finger, that he feels that his food is stuck in his chest, or whether he feels any chest pain during the swallowing process, or there is a generalized burning of sensation and afterwards it is followed by dysphagia. So any pathology related to the chest or downstream from the pharynx, you can fairly confidently classify it as esophageal dysphagia. And then we are going to stepwise rule out the various pathologies by our clinical examination with further detailed history, or if needed, some diagnostic interventions to arrive at a definitive diagnosis. Okay. Let's look at oropharyngeal dysphagia in detail. So we have a fairly good idea with the patient history that the patient has oropharyngeal dysphagia. Next point to consider is whether there is any structural abnormality or any propulsive or motor abnormality causing this oropharyngeal dysphagia. The upper part of the dysphagia process, the oropharynx, generally there are very few propulsive or the conditions that can cause oropharyngeal dysphagia. The major problems involved here are the structural ones or the iatrogenic ones, which we are going to look into it stepwise. In the structural part, there can be a Zenker's diverticulum. As you know, Zenker's diverticulum is a benign pouch which forms in some patients, and this is generally because of the increased tone of the upper esophageal sphincter. The upper esophageal sphincter generally doesn't relax as normally as it does in normal individuals, and this leads to a point of weakness in the oropharynx just above the upper esophageal sphincter, from where a benign pouch forms and the food can get trapped into that pouch. And this can lead to a few other symptoms like nasal regurgitation of food, the aspiration of food. Patients can have bad breath, or which is called halitosis. And so whenever we have a patient presenting to us and he says that whether I do my toothbrushing very normally, but I have bad breath, or I have the inability to pass the food, and I feel that something is stuck in my mouth after I take the food. So we have a fairly good idea that this might be a Zenker's diverticulum. I mean, it is a fairly common process. And then we do some fluoroscopic studies or barium studies to look at it, and then we can arrive at a conclusive diagnosis. Zenker's diverticulum is a fairly common cause of oropharyngeal dysphagia. There can be an underlying neoplasm, for example. There can be a thyroid disorder which can compress the whole oropharynx, a thyromegaly, or some thyroid neoplasm, or any other lymphoid neoplasm which can obstruct and cause an obstructive lesion, or a squamous cell carcinoma of the pharynx, or the squamous cell carcinoma of the larynx, which whenever it increases its size, it can cause a structural problem. This can lead to the hoarseness of the voice as well if it involves a recurrent laryngeal nerve. Then there can be a cervical web in patients with, for example, iron deficiency anemia. A cervical web can form which can lead to the difficulty of the food passing through the oropharynx. Another important point to remember in the structural part of the pathophysiology of dysphagia is generally that whenever there is some structural pathology, the problem is generally with the solid food. The solid food has the inability to pass because of some structural problem going on. The liquid food easily passes. On the other hand, with the propulsive or the motor disorders, there will be an absence of peristalsis or difficulty in peristalsis. So the food problem will involve both the solid and the liquid component. So if the patient says that I have no problem in getting liquids down my throat, then we have a fairly good idea that this is some structural problem. But if the patient says that I have problem in getting both the solids and the liquids down my esophagus, or I have difficulty in solving either the solids or the liquids, then we can have a good idea that this might be a motor pathology going on. Alright, there is a cricopharyngeal valve. The important ones are here. The important ones to remember here are the Zenker's diverticulum, neoplasm, and the cervical web. These are the most common ones. These are fairly uncommon, but for the sense of completion, there can be some osteophyte or some congenital pathology going on in the oropharynx, or post head and neck surgery. This is a fairly common one. For example, if someone has a thyroid neoplasm and he undergoes radiotherapy, and then because of this radiotherapy, there can be some scar tissue or some fibrosis of the pharynx or the adjoining tissue, which can lead to a structural pathology in causing this oropharyngeal dysphagia. So in context of the oropharyngeal dysphagia, the important causes are generally the structural or the iatrogenic, like the radiation or the surgery. These are the main, or there can be some neoplasm. These are the three main problems which can lead to esophageal dysphagia, as you will see. Again, just as I told you, radiation can cause this post some surgery or post some neoplasm. This can cause this oropharyngeal dysphagia. Corrosive injury, for example, if someone has ingested a corrosive, this can lead to scar tissue formation and cause structural dysphagia. So this is a very complete and a thorough list of all these processes, and we stepwise rule out the various pathologies to arrive at a definitive diagnosis in case of any structural pathology of the oropharyngeal dysphagia. Now let's look at what can cause a propulsive or a motor problem. Generally, whenever there is a propulsive problem related to the oropharyngeal dysphagia, it is most likely neurogenic in origin, or something involved with the whole swallowing reflex. Most likely, some cerebrovascular accident. The three main important causes of oropharyngeal dysphagia, if you have to broadly classify it, are iatrogenic, for example, some radiation or post surgery. The structural, which I just completed a list of, and then number 3 is the neurological problems. When there is a neurological problem, there is difficulty in the whole peristaltic wave, or the difficulty in the solving reflex, and the whole system is disrupted. For example, this can happen in someone with stroke. If someone has had a brainstem stroke, this can cause difficulty in solving. For example, a medullary stroke can cause that, or if this can involve both sides, if the stroke is extensive to cause the lesion on the both sides of the brainstem, or this can be unilateral with the deviation of the pharynx in the soft palate in the ipsilateral or the contralateral direction. So in a unilateral cerebrovascular accident, we can say there can be a drooling of the saliva through the angle of the mouth, or there can be some nasal regurgitation or the aspiration of the food. So in patients with stroke, we have to be very careful with their feeding process. We either give a trial and see whether the patient can handle some liquids, and if the patient is able to handle, then we can maybe go on. And with the time, as the stroke patient starts recovering from the stroke or any cerebrovascular accident, the solving process generally improves. But in patients where there is no improvement, we have to then revert to whether there is some NG tube or nasogastric feeding tube or some gastrostomy tube to facilitate the solving. There are certain precautions we have to take in patients with stroke, and for that we employ a solving therapist. The important one is the nasal regurgitation or the aspiration of food into the tracheobronchial apparatus. To avoid the aspiration, it is important to have certain postural changes in the patient with the stroke, or to train the patient or the attendant for all this, and this can be done with the help of a solving therapist. So stroke or cerebrovascular accident is a major cause of a neurogenic problem related to the oropharyngeal dysphagia. Similarly, in patients with Parkinsonism or patients with amyotrophic lateral sclerosis, there are certain neurological problem with some motor problem which can cause this neurogenic pathology. As we go down, these are the major ones: the stroke, Parkinson's, or the amyotrophic lateral sclerosis, or some certain brainstem tumors. The rest of them are fairly uncommon, but for the sense of completion, let's look at them. Any brainstem tumor, as I just told you, can disrupt the physiological process. Similarly, in GBS or Guillain-Barré syndrome, as you know, there is ascending paralysis. This can lead to difficulty in swallowing, but this is very rare because generally the GBS starts from downwards and move in the upwards direction. Similarly, in Huntington's chorea or someone after polio, the post-polio syndrome, multiple sclerosis is another pathology that can manifest itself in the form of dysphagia. So this is a generalized list of the various neurogenic problems that can cause oropharyngeal dysphagia. Cerebral palsy is also one, especially in younger patients. But if you have to remember 3, then look at them. This is generally in descending order of the commonality. For example, the stroke is a fairly common one, or some with Parkinsonism or amyotrophic lateral sclerosis. These are the patients which you are generally going to encounter when there is some neurogenic pathology involving the oropharyngeal dysphagia. Similarly, there can be some muscular or myogenic pathology. For example, myasthenia gravis. As you know that the oropharyngeal apparatus is generally composed of the striated muscle. So in myasthenia gravis, as you know, there is weakness of the neuromuscular junction. This can lead to difficulty in the solving process, or poliomyelitis can cause it. The post-polio syndrome generally neurogenic, but the polio itself is generally myogenic and neurogenic, as you know. Similarly, some connective tissue disorders, for example, as we are going to see later on, sarcoidosis can cause it. Some oculopharyngeal muscular dystrophy or certain paraneoplastic syndromes can present with the myogenic problems. Myotonic dystrophy is another neurological condition in which there is increased tone in the motor system. So these are very rare, these myogenic pathologies. If you have to remember one, I would remember the myasthenia gravis, because this can be fairly common. Apart from the sarcoidosis is another one which is fairly common in the Western world, but it very rarely presents with dysphagia. It has a lot of other systemic symptoms. So as you can see, generally that there are certain pathologies, for example, generally the structural lesions, which will be related to only the oropharynx, and you have to do further diagnostic processes. But if there is certain neurogenic or myogenic problem, it is generally a systemic disorder like Parkinsonism or a stroke or myasthenia gravis. And so the patient will have other signs and symptoms, and the patient is fairly easy to diagnose what is going on. And then dysphagia can either, very rarely, it is an initial manifestation of these neurogenic problems. There will be other neurogenic problems, and afterwards it can involve your oropharynx and cause dysphagia. While on the structural side of things, the dysphagia can be the presenting symptom or the initial complaint with which the patient comes to you. So this is important to remember. You don't have to memorize the whole list, just keep the important ones in your mind and then rule out then step by step via history or clinical examination, and if needed, some diagnostic interventions. Now, let's look at the other side of the picture. Similarly, we are going to classify the esophageal dysphagia as either structural or propulsive. In the oropharyngeal part, the structural lesions are the ones which are very common, while in the esophageal part, propulsive dysphagia is almost as common as the structural ones. In the propulsive dysphagia in esophagus, the important thing to remember is whether there is any pathology in the generation of the primary peristaltic wave or the inability of the lower esophageal sphincter to relax or to allow the food to pass. The conditions which can cause the propulsive or the motor disorders, the common ones are the GERD or the gastroesophageal reflux disease. This can lead to the weakening of the lower esophageal sphincter and the weakening of the peristalsis in the lower esophageal sphincter, and this can cause difficulty in the peristaltic movement and lead to the food getting stuck in the lower esophageal sphincter. So GERD is a fairly common, especially if the patient comes to us and says that I have been having some heartburn for a while, for the last 2-3 months or a few weeks, and afterwards now I have difficulty in passing the food down and I feel that something is stuck in my chest. Then you have to look at it that it might be dysphagia post this gastroesophageal reflux disease, or it can also cause a structural lesion, as we'll see, or like a stricture in the lower esophageal sphincter or stricture in the lower part of the esophagus. We call that reflux stricture or peptic stricture, which can cause a pathology. So either ways, it starts with a propulsive problem and then can lead to a structural problem as well. So this is important to remember in the context of gastroesophageal reflux disease. Moving forward, achalasia is also a very fairly common condition causing the esophageal dysphagia. In achalasia, the problem is generally of the lower esophageal sphincter to relax. There is deficiency of the VIP, vasoactive intestinal peptide, or the nitric oxide in the lower esophageal sphincter during the inhibitory phase, and it leads to the constant excitation of the constant vaguely monitored tone of the lower esophageal sphincter. So the lower esophageal sphincter has difficulty in relaxation, and similarly the peristaltic wave is also disturbed. So there is increased tonicity in the lower side of the esophagus, which leads to the food getting stuck upwards in the chest or in the esophagus. So achalasia is a common condition to remember in this context. Similarly, there is a condition called DEC or diffuse esophageal spasm, in which there is a generalized increased tone of the gut, but the contractility is diffuse and there is an inability to create a propulsive or a peristaltic wave. This can present as chest pain in patients, and the patient can have similar manifestation. We can sense that the patient might be having an MI. So we have to do an ECG of the patient with any patient presenting with chest pain as well. So the esophageal dysphagia generally presents with chest pain, or the patient says that I feel that food is stuck here. The patient localizes to the chest, points to his chest. So to complete the propulsivity, these are the ones which are very common. GERD or achalasia or the diffuse esophageal spasm. Then there is a condition called scleroderma, as you know. In scleroderma, there is generalized tightening of the skin. It's a musculoskeletal problem, and it can involve the esophagus as well. So because of this tightening, there can be lower esophageal tightening, or the lower esophageal sphincter can get tightened, and there will be difficulty in the food passing by, and it can also involve the motor part. It can also cause difficulty with the peristaltic move. So scleroderma can present as either a propulsive problem or a structural problem. It has components of both. The propulsive problem is related to the inability of the primary peristaltic wave generation, and the structural pathology is because of the thinning or the tightening of the lower esophageal sphincter, which can lead to this dysphagia. So it has components of both this part. Now let's look at some structural pathologies. Structural can be divided into whether the dysphagia is intermittent or continuous or progressive. If there is intermittent dysphagia, the patient says that sometimes I have problem in passing the food, sometimes it is fairly fine. So this is an intermittent condition, and if it is not progressive, the patient says that it is not, the frequency is not increasing, then this can be a generalized benign Scarzi ring. This is a benign ring form or a constriction of the esophageal lumen, or as we saw in the oropharyngeal structure, there can be a web similarly to the oropharyngeal dysphagia structural problem. This esophageal web can be related to iron deficiency, anemia, or these are fairly benign conditions, and with the passage of time, they get better, or they are not a lot of discomfort for the patient. Now, if the patient's dysphagia is progressive, the patient says that initially I had a very little problem in passing the food. Now with the passing of time, I have problems in passing the food, especially the solid food. Then then this is a very important red flag for any progressive lesion which is trying to constrict the lumen of the esophagus further. So in this context, we have to keep the neoplasm in the mind, and then we have to look at the general condition of the patient, and with the help of the various investigations which we are going to discuss in the coming slides, we are going to rule out the neoplasm. It is very important to rule out the neoplasm if there is some progressive dysphagia history. And now, afterwards, if there is some variable problem, sometimes it happens, sometimes it doesn't happen, then has a long list of pathologies which can cause. The important ones to remember, as I just told you, in the context of GERD, is the peptic stricture. If the patient has gastroesophageal reflux disease, initially it can cause some propulsive problems in the lower esophageal sphincter by the weakening, but later on, because of the metaphasia or metaphysiological changes going on, the lower esophageal histology is changed, and this can lead to a stricture in the lower part of the esophagus. And this can present then as a structural problem. And further going on, it can also transform into an adenocarcinoma of the esophagus. So it is very important to rule out this problem, and we have to treat it as early as possible to provide comfort to the patient. Similarly, another important condition is eosinophilic esophagitis. You can remember it as an allergy to certain food particles in certain patients, generally young patients, which can present with this esophagitis or inflammation of the esophagus. When the patient takes those foods for which he has allergy, there is generalized thickness of the esophagus, and the eosinophils get accumulated, similar to as you saw in patients with atopy or asthma or any allergy to anything. So in these patients, when we do the histology, we see a lot of eosinophils, and this is a condition which is becoming fairly common now. We label the patient as having eosinophilic esophagitis. You can also remember it as a diagnosis of exclusion, as after we have ruled out the various pathologies and the symptoms haven't revolved, then we go to the mouth with the help of an endoscope, take a biopsy of the few areas, and then when we look at those areas in the histopathology sample, and if there is generalized eosinophilia, then we label the patient as having eosinophilic esophagitis, and then there are certain precautions that patient has to take to avoid this condition. There can be a hiatal hernia underneath, some extrinsic compression, for example, compression from some lymphoma or anything that can compress the esophagus somewhere. There can be a stenosis post-surgically because of the scar tissue or the radiation. And similarly, there can be some congenital problems leading to the structural lesion, similar to the oropharyngeal part. The important ones to remember here are the neoplasms, the peptic strictures, or certain rings, or eosinophilic esophagitis. These 3 and 4 are the ones which you have to remember in the context of the structural lesions. And another important point to remember is the structural lesions, whether they are oropharyngeal or esophageal, they generally present with dysphagia to the solids only. If there is dysphagia to liquids as well, along with the solids, then there is generally a motor disorder going on, and we have to go likewise for that motor disorder. Pill esophagitis is also becoming a common condition. That is because of certain, after the ingestion of some corrosives, you can say, or certain medications which have a side effect of esophagitis, and then you have to take certain precautions. For example, take that medication where you are sitting upright, and drink with a lot of fluids to avoid this esophagitis or the pill to pass quickly through the esophagus. Infectious disease processes can also lead to some structural disease. For example, as I told you, In patients with HIV, there can be CMV or Kaposi sarcoma, or all these problems. Causative injury because of certain causative agent, which can cause the esophagitis, which can cause the burn of the esophagus if you ingest a dye or any alkaline thing. This can cause an injury to the esophagus. Chemotherapy in patients with tumor, for example, in patients with tumor of the thyroid and which undergo the chemotherapy, this can cause the esophagus. Sclerotherapy is also the similar thing. Crohn's disease is another important one. It generally involves the gut, but it can also present as dysphagia. But this is fairly very rare that for Crohn's disease to present with the esophageal pathology. It generally involves the gut, as you know, and this is a very rare condition. You don't have to remember all these things. This is just for the sake of completion. Now, let's look at the important parts. You have seen the physiology, the pathophysiology. Now, let's look at certain signs and symptoms with which the patient can present with dysphagia. The patient will say that I choke on my food or drink. Whenever I eat or drink, I have some choking sensation. The food has difficulty in passing. If there is oropharyngeal part of dysphagia, it can present with coughing or during or after swallowing, or it can present with some regurgitation or vomiting up of food. So this is an important sign and symptom. Cough can also be a symptom of cough, or the hoarseness of voice can also be a symptom of the recurrent laryngeal nerve irritation, which can be because of certain underlying neoplasm. So this is important to rule out. The patient can have a weak or a soft voice. Aspiration, as I told you, especially in the context of the neurological problems, aspiration is a very important thing. The patient, this may be a presenting complaint of the patient. The patient presents to you in ER with some aspiration pneumonia. And then when you start your workup of the aspiration pneumonia, you look into the history of the patient, there is certain underlying neurological problem going on. So this can be helpful in the broader context of the generalized health of the patient. That's why it is very important to have a detailed history of, especially of the neurological part, and the oropharyngeal history or the examination or the musculoskeletal history, to look at the things from a broader perspective rather than just focusing on the dysphagia. You have to look at the patient as a whole, that what is the problem going on, whether this problem is related only to the oropharynx or the esophagus, or it's the generalized condition which is presenting as dysphagia. If there is excessive saliva or drooling of the mouth along with this dysphagia, then this is a problem in the oropharynx or the pharyngeal part. You have to look at whether the patient has difficulty in swallowing or chewing down the food, or whether there is certain lesion in the pharyngeal part which is preventing the food to go through your pharynx and it drools out from the mouth. Or there is a missing teeth which can cause difficulty in chewing, or some weakness of the oropharynx which the patient has difficulty in chewing. There is trouble moving food to the back of your mouth, where there can be a transfer dysphagia or certain problem in your oropharynx in which you are unable to transfer the food to the back of your throat. And the patient says that I have food sticking in the throat. This is the generalized way of saying that the patient has difficulty in passing the food. So these are the various generalized signs and symptoms with which a patient presents with dysphagia. After we have taken the history of the patient and have all of these things in the context, we move on to the next step, to the physical examination. And we tailor a physical examination according to the patient's history, whether we think that this is a generalized problem or a localized problem. If we suspect that this is a generalized problem, then the important things to look on is, for example, if a patient presents with a drooling of the saliva, or there is certain deviation of the angle of the mouth, or you suspect that there is some neurological problem like the weakness, or there is hypertonicity, or you suspect some palsy like a Berber or pseudobulbar palsy, it is very important to do a thorough neurological examination, the examination of the cranial nerves, looking at the gag reflex of the patient. So this thorough neurological examination can give us a fairly good idea of whether we are dealing here with some cerebrovascular accident acutely, or there can be an underlying Parkinsonism or some certain other neurological muscular weakness or a neurological problem with which the patient is presenting. So neurological examination, especially in the context of oropharyngeal dysphagia, is very important because it can be very helpful in localizing our problem, whether it's a brainstem issue or any other pathology which is interfering with the normal solving mechanism. Similarly, a generalized neuromuscular disease like myasthenia gravis or GBS, it can present with dysphagia. So, continuing on from the neurological examination, you have a neuromuscular exam. A muscular examination is also very important. Look at the power of the patient, the reflexes. So, a generalized neuromuscular examination and nervous system examination is adamant to diagnosing the oropharyngeal dysphagia, especially. Similarly, the neck examination, after you have done the thorough examination, you look into the patient's oral cavity, whether there are certain missing teeth, or you look at with the help of a laryngoscope, you can look at the larynx as well. You can have a neck examination to see whether there is some thyroid abnormality that can be causing constriction of the pharynx and leading to the structural problem. Mouth and the pharyngeal lesions, as I just told you, you just ask the patient to open a mouth with the help of a torch. You examine the oral cavity, whether there are certain lesions or certain problems in the pharynx, some inflammation or pharyngitis that can be leading to this dysphagia. So we have to look at the obvious first. For example, there can be a missing teeth or some mouth or the pharyngeal lesions that can interfere with the swallowing or the chewing process. So you examine the oral cavity, you look at the larynx with the help of a laryngoscope and the pharynx, and then you look at the complex things like the muscular problems or the neuromuscular problems. Going onwards, there can be certain skin or the muscular problems, musculoskeletal problems, which can lead to dysphagia as well. For example, if a patient presents to you and they have generalized tightening of the skin and they also have complaint of dysphagia or reflux, then you can have a fairly good idea that this patient has scleroderma and this dysphagia is a manifestation of scleroderma, or lichen planus or pemphigus vulgaris. These are a few skin conditions that can present with dysphagia as well. So the important thing here is to look at the patient in the general context and go from there, whether the problem is localized in your opinion after your history taking, or there can be a generalized problem, and then accordingly do a neuromuscular or generalized musculoskeletal exam in this patient, looking at the various factors. Afterwards, when we have a good idea of what's the cause, we confirm our diagnosis with the help of a few diagnostic procedures. This is according to the cause. So if we suspect that there is some oropharyngeal dysphagia going on, so the oral part and the pharyngeal part is very quick. For example, after you masticated, the oropharyngeal part lasts just for a second. So there are very few diagnostic procedures which we can do to visualize that part. The most important one is fluoroscopic swallow study. So we ask the patient to ingest a dye, and then when the dye is passing through the oropharynx, we look at the various factors or whether there is some diverticulum, for example, a Zenker diverticulum in which the dye is accumulating, or there is some tracheoesophageal fistula through which the dye is passing into the trachea and the patient has difficulty in breathing or aspiration of the food. So the fluoroscopic studies are the gold standard to diagnose the oropharyngeal part. This is in live patients. The patient has to be conscious and awake, and we ask the patient to ingest this fluoroscopic material, and then we look at his oropharyngeal part in a live picture and see what's the problem going on. Similarly, in a patient with oropharyngeal dysphagia, we have to go through especially if the patient has some aspiration or the regurgitation of food, we have to look at the ENT or the otolaryngoscopic evaluation and the neurologic evaluation. The patient might be having some stroke. We might have to image the brain with the help of a CT scan. So for oropharyngeal dysphagia, the gold standard is the fluoroscopic swallow study, and then the adjoining neurologic and the ENT evaluation is also important. On the other hand, for patients with esophageal dysphagia, the gold standard is the upper GI endoscopy because this gives us the best picture of what is going on in the esophagus. And similarly, this can also be therapeutic as well, because if there is some stricture or certain narrowing, we can open it up with the help of an endoscope. Or if we suspect some infectious pathology, for example, in patients with CMV or eosinophilic esophagitis, or we suspect some lesion in the esophagus, we can take a histological specimen of the biopsy. We can biopsy the specimen and look at it afterwards. So the gold standard for esophageal dysphagia is upper GI endoscopy. As I told you, this can be therapeutic. For example, if certain narrowing of structure is present, we can dilate that part of the esophagus with the help of a endoscope as well. In eosinophilic esophagitis, with the help of an endoscopy, we take the mucosal biopsies throughout the esophagus of various parts, the upper part and the lower part, and then we look at it histologically what is going on. For motility disorders, again, the number one thing you have to do is endoscopy. The endoscopy will not tell you anything about the motility disorder, but this is done to rule out some structural lesion which is occurring in the patient. After the structural lesions are ruled out with the help of an endoscopy, then you can proceed and safely say that this is the motility disorder. And for motility problems, the gold standard is the esophageal manometry, the manometric studies or the pressure studies. So if you have to go through stepwise in any esophageal dysphagia, number one thing to do is endoscopy to look for structural pathologies. If there is any structural lesion and it is fixable with the help of an endoscope, we do that esophageal dilatation with that. And afterwards, if there is no structural pathology and we suspect that this can be a motor problem, then we do the manometric studies to evaluate the tone of the esophagus, the primary peristaltic wave, the pressure in the various compartments, the pressures in the esophageal sphincters. Similarly, barium radiography can also be helpful in those patients with motility disorder. For example, in patients with achalasia, the diagnosis is made with the help of a manometry. But with the barium radiograph, we can see that word big deformity, that the esophagus is narrowed in the lower part and there is impaired relaxation. So this can help us, along with this manometry, to arrive at a definitive diagnosis. For example, we have a manometric study and we have diagnosed the motility disorder. Now we have to differentiate whether this is achalasia or certain other pathology. Then with the help of a barium radiograph, this is helpful and to rule out the various causes of the motility problems. If there is some subtle or complex esophageal sphincters, you can do computed tomography or the CT scan to see whether there is some underlying neoplasm or underlying pathology that can be causing the stricture. Or we can help. This can also be helpful in staging the disease. For example, after we have done the endoscopy and taking the biopsies and have diagnosed that there is, for example, some underlying carcinoma, we do a CT scan to stage the disease. The important thing here to remember is that along with the CT scan, you can also do an endoscopic ultrasound. This requires a lot of skill, and this is done fairly rarely to evaluate any pathology. So in this whole chart, the important thing to remember is that for oropharyngeal dysphagia, the gold standard is the fluoroscopic swallow studies. For esophageal dysphagia, the stepwise process is we do an endoscopy, and afterwards, if we suspect that there is some motility disorder, then we do some manometric studies and the barium radiograph to diagnose our pathology definitively. Here is a diagram of a fluoroscopic swallow study. You see this white thing is the fluoroscopic dye which the patient has ingested, and there is some problem here going on, which is leading to the inability of the dye to pass underneath. You see here that there is dye stuck in this upper part of the esophagus, and there is no dye underneath. This black arrow is denoting that the epiglottis is closed and the larynx is also closed. So this shows that there is some certain obstruction in the oropharyngeal part, which is not letting the dye to pass through the oropharynx, and this is a classic oropharyngeal dysphagia. And then we look at the other various investigations to definitively diagnose that what is this problem that is causing this dysphagia. This is the classic diagram of a manometric study. On the x-axis we have the pressure, and on the y-axis this is the length along the esophagus. This shows the upper esophageal sphincter, the proximal esophagus. This is the distal esophagus all the way up to the esophageal gastric junction. So these are the various pressure readings in the proximal esophagus and the distal esophagus. Then along with the patient solving something, we look at the various pressures in the various compartments, and with the help of these pressure we can diagnose whether the problem is in the lower esophageal sphincter or whether there is a primary peristaltic problem. So these are the pressure waves that help us in evaluating some propulsive problems of the esophagus. Now, after we have diagnosed the patient, the next point comes here, the treatment. And as you know, the treatment is according to the cause. So if we have some oropharyngeal dysphagia, for example, in a patient with stroke, and the patient is unable to swallow the food, or we suspect that the patient might aspirate, the alternatives are that we do a gastrostomy in that patient, an opening in the stomach, and we feed them through that gastrostomy tube, or with the help of a nasogastric tube, we can feed the patient. Similarly, if we have some muscular problems like myasthenia gravis or poliomyositis, the medical treatment of these primary disorders will eventually increase the solving process as well. So after the medical treatment, this is the primary way to go. But if there is a certain problem still remaining and medically the patient is unable to be treated, we can do the cricopharyngeal myotomy. For example, if there is some problem like in Zenker's diverticulum or myotonic dystrophy, where there is increased tone of the upper esophageal sphincter, we can make an opening in the muscular wall, and this can lead to this can fix the oropharyngeal dysphagia. So it is generalized according to the cause. If there is some generalized pathology, we treat the disease, we treat the dysphagia. If it is localized to the oropharynx, then we just go and directly, if it is fixable, we fix the oropharyngeal pathology, and then, or if in case of patients with stroke who have a problem or difficult in solving, we can resort to the alternatives like the gastrostomy or the enteral feeding. Similarly here, just as I told you in the stroke patient, if there is some chronic neurological disorder like Parkinsonism or Huntington's chorea or other things, we can go through the NG tube for those patients. Looking at the other side, in esophageal dysphagia, if there is some stricture or narrowing, and if it is fixable with the help of an endoscope, then we do the esophageal dilatation, and we just open that lesion or open that stricture, and the food is now easily passing through that problem. If it is not fixable with the help of an endoscope, then we might have to do the surgery to remove that part. For example, esophageal myotomy is a procedure in which we create an opening, or we loosen the muscular part in the lower esophagus to relieve the obstruction, or if there is tightening of the lower esophageal sphincter and the ballooning dilatation isn't helping, then with the help of various surgical procedures, we can fix that problem. And if there is certain infectious pathologies going on, for example, some bacterial pathology or some viral pathology, then antimicrobial medications are helpful, especially in patients with immunocompromised history, like HIV patients who present with Candida esophagitis or Kaposi sarcomas. Then the antimicrobial or the antifungal medications are helpful in fixing those pathologies. And in patients with eosinophilic esophagitis, or who have an allergy to the food, the important thing is to look at what are the food allergens that cause this problem. And elimination of those dietary allergens is very important. And if that does not help, then an alternative is that we give the patient swallowed glucocorticoids. We make the patient we give them inhalers with which we buffer them with the help of a glucocorticoid like fluticasone in their mouth, and those glucocorticoids help with the inflammation process in the esophagus. So this is the generalized treatment plan. It is generally according to the cause, whether it is oropharyngeal or esophageal, whether it is fixable with the help of an endoscope, or whether we have to do surgery. So it is fairly straightforward, and if you know what is going on, you can easily make out how do we diagnose it and how do we treat it. This is all for the dysphagia lecture. I hope you have learned something new today, and I'll see you in another lecture.